Hello, I'm Dr. William Berger, owner and founder of Northeast Medical Practice. We are a concierge-style internal medicine, weight management, and aesthetics practice located in Great Neck, New York on Long Island.
Good afternoon, and I'm Irina Berger. I'm Administrative Director at Northeast Medical Practice. Dr. Berger, I know that this week it's Obesity Care Week, and I would like to ask you if you can tell me a little bit about development in obesity medicine in a year, and also what can we anticipate, what is coming in the world of obesity.
It'd be my pleasure. It's been a very exciting year in the field of obesity medicine. So many new developments. I just want to hit some of the highlights. In terms of anti-obesity medicines or weight loss medications, the GLP-1 receptor agonist family of medicines has really been dominant. So here we're talking about semaglutide and tirzepatide. Semaglutide in the form of Wegovy, the branded version for weight loss, was shown in the SELECT trial to decrease risk of recurrent heart attack or stroke in patients who are unfortunate enough to have those things at least once before, to reduce the risk of another event by 20%. So a really significant advance in terms of what we call secondary prevention in the cardiovascular disease world. And for that reason, it was the first time that something branded as a weight loss medication was actually approved by Medicare. Not for the weight loss per se, but for the decreased risk of recurrent cardiovascular event. But still, a major stride forward in terms of decreasing the risk of those unfortunate things happening again, but also for Medicare coverage for one of these types of medicines. Really continue to see really great results in our patients, and we see this throughout the medical literature, both Wegovy and Zepbound being the weight loss branded version of tirzepatide in injectable forms for patients. We have great luck with them as well. But now we have the advent of an oral version of Wegovy that is now approved and available from Novo Nordisk. It has just about the same effect over the course of 1 year in terms of weight loss on average as the injectable form of Wegovy does.
And it's much less expensive.
It is less expensive, and this is another thing that has been happening throughout the year, is that for those folks whose insurance unfortunately doesn't cover these medicines, both of those major manufacturers, Eli Lilly and Novo Nordisk, their cash pay options direct from the manufacturer, the prices have continued to decrease. Hopefully we're going to see that continue. Maybe we're going to see some version of Medicare coverage for these medications outside of secondary prevention of heart attack and stroke in 26. I hope that we see that. And of course there are a lot of additional medications, really dozens of them in the pipeline that are coming in. I'll just hit on a few of the major ones that are going through phase 3 clinical trials right now, and if they're approved are likely to really be significant players in this space as well. So one is retatrutide. This is a triple agonist medicine, so it's also put out by Eli Lilly, just like tirzepatide, which was our first dual agonist medicine. So by that I mean that it stimulates more than one receptor, so not just the GLP-1 receptor. In tirzepatide you have GLP-1 and you have GIP receptor stimulation or agonism. And in retatrutide, we're going to have triple, so that's GLP-1, GIP, as well as the glucagon receptor. And from the data that we're hearing about, there's going to be even more weight loss on average than was seen with tirzepatide. So really getting well up into the range of weight loss that could be expected by some types of bariatric surgery.
Wow.
So it's that's likely to be a really effective tool for us to have in our toolbox, assuming that it makes it through phase 3 and is approved by the FDA. There are a couple of others. So Lilly also has an oral medication called, I always have trouble pronouncing it, orforglipron. So this isn't a peptide like tirzepatide and semaglutide are. It's a small molecule, and that allows them to prepare it more easily as an oral formulation. So it's a GLP-1 receptor agonist medicine, but it's not a peptide. It's a different type of small molecule, and it's oral, and that's also in phase 3 clinical trials and shown to be pretty effective as well. So giving us another potent oral option, assuming that it's FDA approved and so forth.
Do we know the side effects from the oral medications? Are they similar to the injectables?
So the one new oral is the oral Wegovy, and its side effect profile is pretty similar to the injectable version of Wegovy. So it's primarily gastrointestinal, because one of the effects of semaglutide and in any GLP-1 receptor agonist is to slow down gastric emptying. So there can be some nausea, there can be some constipation, sometimes paradoxically some diarrhea. But generally, those are the types of side effects that we see with the oral Wegovy, similar to the injected one.
And another question I had, you mentioned about the percentage of weight loss. Can you go over and remind what would be the breakdown? Like, I know Saxenda it's 10%, and the Zepbound, I believe it's 20. Can you just talk a little bit more about that?
Yeah, Saxenda probably even was a little less than 10%, and not used as often. It's also a daily injected medication. But for semaglutide, whether we're talking about injected or oral, somewhere 13-14% on average once the patient's been on their maximum dose for a year. Tirzepatide, Zepbound being the weight loss version of that as a brand name, around 20-21%. And what we're seeing in the retatrutide studies, it's probably going to be north of 23 or 24% weight loss. We'll have to see once everything is finished and published and so forth. But really significant levels of weight loss. And also it seems to target fat and perhaps spare muscle better than some of the other medicines we have. I'm referring to retatrutide here. There's also another triple agonist medication in phase 3 clinical trials called CagriSema. This one also stimulates the amylin receptor, so that it also helps to really control appetite. Initially, there was some thought about this also sparing muscle. In the most recent study, maybe not quite so much, but definitely significant weight loss, probably beyond what we've been seeing with the medications that are currently FDA approved. So a lot of new options that are probably going to become available in the coming months, which is really exciting. But my concern is always, okay, all of this gets a lot of press, and it really should. These are revolutionary types of medications. But I just don't want the importance of lifestyle to be pushed to the side because these medications are so effective and they tend to grab so many headlines. As we both do in our work in the clinic, we really try to focus on lifestyle here and its pillars as foundational, regardless of whether we're using medication or not. So the diet and nutrition, the physical activity, sleep as really being foundational for everything, managing of stress and so forth, that I work on from a medical side, that you work on from the well-being coaching side, and that Peter, our exercise physiologist and nutritionist, also works on from his perspective.
Yeah, it's a tool in the box. But let me ask you, what are your thoughts? Like some of those drugs, they're relatively new, and there is a lot of stigma about taking them in the long run. What are your thoughts overall? What are you thinking? How safe are those drugs?
Any new medication, we're going to continue to collect new data. They go through very vigorous trials, 3 different phases, determine safety, then efficacy. But of course, data continues to be collected in what we call phase 4, which is really reporting of side effects and anything that happens with the medications once they're available to the population. But GLP-1 receptor agonist medications in general have been around for over 20 years. So we have really good data showing that they are relatively safe. No medication is without any risks. But in my mind, the benefits for a large percentage of our patients generally outweighing the risks.
And I want to ask you about the safety, because it's not, everybody's trying to get into the space of weight management, because again, it's, revolutionary drugs and so forth. If you, someone who is looking for a doctor, what credentials would you look into? What is important when you're choosing weight management doctor?
So while any physician is capable of prescribing these types of medicines and so forth, I do think that it is very helpful to seek out someone with a certification from the American Board of Obesity Medicine, because those of us who hold that have really gone through intensive study beyond what, as an internist, I got in my training with regard to the management of adiposity. Endocrinology, of course, is also, they're very highly trained in all of this as well. But to have the ABOM certification, and a lot of endocrinologists go and obtain this as well, because it really gives you a really deep focus just on the obesity medicine part of the puzzle. So it's not a requirement for anybody that prescribes these medications, but I think it's definitely shows additional training, knowledge, and savvy ability to help people with their weight.
And what OMA stands for, the compound medicine? Can you elaborate? Because there are a lot of meds you can purchase online for $99, and so again, safety is always number one, and I just want to make an emphasis about the importance of quality of care and also safety.
Right, so here you're referring to the Obesity Medicine Association, one of the professional organizations for people practicing in the obesity medicine space. So yes, there is a clinical practice statement that is, I'll say, not favorable in terms of its outlook on compounded weight loss medications. I feel the same way about it, because the most compounding pharmacies are not of the FDA regulated type that provide antibiotics and IV fluids and things to hospitals when there's a shortage. They aren't quite as regulated, and there is no longer a shortage, so technically these kinds of medications are not meant to be available any longer, although sometimes they are modified with the addition of vitamin B12 or other sorts of things to allow them to the compounding pharmacies to provide these, but they're just not made under the same degree of supervision and scrutiny as pharmaceuticals are when they come from the manufacturer. And there are other options. There are generic medications. Saxenda, which you mentioned already, is actually old enough to be available as a generic now. So there are other older oral medications as well that are available as generic. So in terms of
Qsymia, right? I mean, all those, I hear you.
their components are available as generics, Contrave and Qsymia. So there are a lot of options in terms of when price and insurance coverage are issues, but I personally and the Obesity Medicine Association in general are a little bit cautious when it comes to thinking about the compounded weight loss medications.
And I think the cost might be a phenomenal opportunity for people to go safe route, because before, for injectables it would be $1,300-$1,200, and often insurance wouldn't cover. So if you see young girls who would like to lose weight and aesthetically to look good, they just look online and they purchase those compound meds, and you have no clue what goes in them, right? And it's really, I like the statement of, if you're choosing a doctor, make sure that they all may certified, and also it's also FDA approved. It goes through clinical trials, and you exactly know what goes in them. Okay, thank you, Dr. Berger. Anything else? Maybe disclaimer?
Yeah, the disclaimer, but also I'd like to say I do hope that the newsworthiness of this entire space of weight management and so forth is, I hope, decreasing the stigma surrounding obesity and its nature as a chronic disease and so forth. So regardless of whether people are mostly talking about medications as opposed to lifestyle, I think the fact that it's being discussed more and more is going to help us to change the way obesity is perceived, and not as a matter of will, but as a chronic disease, and that we need to approach it that way.
What are your thoughts on rapid loss? Like, I know that it kills your appetite and you don't have, and of course there is a huge emphasis on maintaining muscle mass, and we constantly, talking about protein intake and exercise. But tell me a little bit about, like, sometimes we, patients experience very rapid loss of weight, and is it good to lose 10 pounds in a week? Like, what are your thoughts?
No, it's not. I don't like it to go probably much quicker than 8 or so pounds in a month, because you increase risk for gallstones as you change the weight that quickly, but also, really importantly, that, like you mentioned, the loss of muscle mass. It's very likely that if you lose weight that quickly, you're also losing a significant proportion of it as skeletal muscle mass, and it's difficult regardless of your age, but as we all get older, it becomes even more difficult to put it back on, to replace it. So no, I don't recommend people try to lose it too quickly. Exactly.
And also experiencing hair loss. Sometimes we see
Yes,
this
that's
in
another.
patients as well.
That's another, because weight loss is viewed by the body as a stress, just like delivery of a baby is a stress, and women often have telogen effluvium, diffuse hair loss after birth, and losing weight that quickly is a stress, and the body says, okay, it's not time to make more hair. We're going to stop that part of the hair cycle. So yeah, it's not a healthy way to lose weight if it's too quick.
Yeah, even if you don't have desire, your body still needs minerals, vitamins, protein. Like, you really need to have a plan how to eat. You need to plan how to exercise, because again, muscle mass is essential. Maybe it's not issue right now, but when you turn at the age of 75 and above, it would be essential for you.
Right.
You need
just to perform your daily activities of living, all the things that you'd like to be able to do in your older years, but also to decrease your risk for falls and fractures. It's really important to try to maintain skeletal muscle mass.
And we were listening Peter Attia, and one of the things he was talking, when you turn 75, physical and mental decline is like 50%. So in order
the rate
for
of decline
you,
increases at that age, yes.
and in order for you to have a last decade of your life, quality of life, you gotta put those investments now. Like, you gotta work and really.
Exactly. And if we're causing people to lose muscle mass while we're managing their adiposity, we're not doing them a service, we're doing them a disservice, because it's going to make that much more difficult down the road.
Thank you.
My pleasure. So remember that everything that we share in these videos is for educational purposes only. No doctor-patient relationship has been formed. If you have particular questions or concerns about your health, please don't hesitate to reach out to your healthcare providers. However, if you'd like to learn more about what we can offer here at Northeast Medical Practice to help you optimize your health, you can reach out to the office in Great Neck, New York, 516-604-3418, online at northeastmedicalpractice.com, through our various social media channels, including our YouTube channel and our LongevityMD podcast available on Spotify. But until we see each other next time, be in good health.
Be in good health. Bye-bye.